Water is heavy. Descending just 33 feet places a human body under twice the atmospheric pressure experienced at the surface. This hyperbaric environment compresses gases in the lungs, forces nitrogen into the bloodstream, and severely magnifies any underlying physiological weaknesses. For decades, the diving industry managed this risk with a blunt instrument. Medical clearances relied on broad, blanket exclusions. If a candidate had a historical diagnosis, even one that had not presented symptoms in years, they were often permanently barred from the water. In 2020, the Diver Medical Screening Committee, or DMSC, replaced this rigid framework with a new standard. Their system is engineered using current, evidence-based medicine to accurately identify real risk, while allowing candidates with low-risk profiles to dive without unnecessary barriers. Developed by an independent international panel of diving medical experts, the protocol carries the formal endorsement of both the Undersea and Hyperbaric Medical Society and Divers Alert Network, establishing it as the global authority. The DMSC protocol functions as a precise three-part filtering architecture. It is designed to protect patient privacy, shield dive operators from legal liability, and equip general physicians with the exact references they need to make highly specialized hyperbaric risk assessments. Robust medical screening is not an administrative hurdle. It is the mandatory clinical practice for preventing foreseeable medical emergencies underwater. The protocol begins with Part 1, the Diver Medical Participant Questionnaire. This is an initial self-declaration screen completed by the diving candidate to quickly filter out individuals with no significant risk factors. This diagram outlines the logic of the initial screen. It asks 10 baseline medical questions. If the candidate answers no to all 10, the process stops there, and they are cleared to dive. But answering yes to specific initial prompts, like questions 3, 5, or 10, mandates a branch into a second page of more granular inquiries, labeled boxes A through G. If the candidate answers yes to any of the detailed questions within those specific boxes, the self-assessment ends. It triggers a mandatory formal review by a medical doctor. This brings us to Part 2 of the system, the physician's evaluation form. This document is only activated when a candidate is explicitly flagged by the initial questionnaire. The physician's form features a deliberately restrictive design. It offers the evaluating doctor exactly 2 checkboxes, approved or not approved. Older iterations of dive medical forms included an additional comment section. The DMSC expressly removed this. Dive instructors lack medical training. Providing them with conditional clearances, or written doctor's notes, forces them to interpret clinical data, a massive legal liability. A strict binary choice prevents them from having to make medical judgments. Furthermore, the detailed questionnaire containing the candidate's sensitive health data remains with the physician. Only the single page containing the binary approval is returned to the dive operator. This 2-part workflow creates a strict liability firewall, completely severing administrative processing from clinical judgment. When an evaluation is required, the doctor utilizes Part 3, the diving medical guidance document. Most general practitioners do not receive specific training in diving medicine or hyperbaric physiology during medical school. The guidance document bridges this expertise gap. Organized by medical specialty, it categorizes specific health conditions into severe, relative, and temporary risk tiers. A severe risk designates conditions where an individual faces a substantially elevated probability of injury or death under pressure. A relative risk indicates a moderate increase in danger, requiring the physician to make an individual clinical assessment. A temporary risk simply precludes diving until the specific condition, like an acute infection, fully resolves. The protocol also offers operational flexibility. Physicians can conduct these evaluations via telemedicine, provided the flagged conditions do not require an in-person physical examination of the heart or lungs. By supplying a clear, stratified risk framework, the system empowers standard clinicians to make confident, defensible fitness-to-dive assessments, even without formal hyperbaric specialization. To understand how these evaluations work in practice, we have to look at the clinical reasoning inside the guidance document, beginning with respiratory risk. Historically, a simple diagnosis of asthma meant an automatic disqualification from diving. The modern criteria reject this blanket prohibition. Physicians are now instructed to evaluate the patient's active disease control. The key metrics are current triggers and whether the patient has experienced an asthmatic exacerbation within the last 12 months. This animated scale illustrates why body mass index, or BMI, was deliberately excluded from the DMSC screening system as a valid metric. BMI is strictly a height-to-weight ratio. It severely penalizes individuals with large frames and high muscle density, while entirely failing to detect poor cardiovascular health in individuals with smaller frames who carry more fat mass. Both can output exactly the same score. Evaluating physicians must prioritize general cardiac fitness and true body composition. Neither of these critical health factors can be extracted from a BMI calculation. The DMSC system explicitly discards imperfect, static metrics, forcing the evaluation to focus on the dynamic, functional reality of a patient's current health. This functional approach also applies to sleep disorders. Obstructive sleep apnea, or OSA, is flagged in the guidance document as a prominent relative risk condition. While it happens during sleep, OSA serves as a powerful independent risk factor for broader cardiovascular disease. In this model of a beating heart, interrupted breathing from sleep apnea places intense mechanical stress and accumulating pressure directly on the right ventricle. This accumulated right ventricular strain drastically elevates the probability of arrhythmias. Underwater, a sudden cardiac event usually results in fatal incapacitation. Neurological assessments follow similarly precise logic. Active epilepsy, defined as recurrent, unprovoked seizures, remains a severe disqualifying risk, but a remote history of a single seizure does not. This timeline chart shows the precise statistical reset threshold established by the DMSC. To be considered result, an individual must remain entirely seizure-free for 10 years, and they must be off all related anti-seizure medication for the last 5 years. Once a candidate meets these exact chronological milestones, their statistical probability of experiencing a seizure underwater drops to match the baseline risk of the general population. By utilizing these precise clinical distinctions, candidates who have thoroughly resolved or meticulously managed their medical histories are no longer unfairly excluded from the water. The screening protocol is built to continuously adapt to new medical evidence. The guidance document and the questionnaire undergo active, ongoing revisions driven by data from the UHMS and DAN. The rapid implementation of post-COVID-19 protocols demonstrates this agility. As the virus showed unpredictable long-term impacts on critical cardiopulmonary systems, the DMSC quickly integrated specific symptom checks into the questionnaire. Ultimately, the questionnaire cannot list every human ailment. Any severe unlisted health concern or an evolving physiological complication always dictates a formal medical evaluation to prevent an emergency requiring extensive clinical intervention. The DMSC protocol achieves a difficult balance. It safely maximizes recreational participation while efficiently filtering the exact subset of individuals who genuinely require specialized review. It also maintains a strict operational boundary. Dive professionals administer the data funnel, and licensed doctors provide the clinical judgment. By trusting current, evidence-based metrics over rigid historical exclusions, this dynamic screening protocol has successfully established a universal, modern culture of safety for the entire recreational diving industry.